Afternoon. So today I'm going to be talking about cardiac arrest, which you guys are all very familiar with, but what I'm going to do today is kind of some general review, some statistics, show you what I do in the hospital after you guys have done your thing, and then we'll talk about what's new from an arrest standpoint. So some basic statistics. We'll talk about changes in ACLS from 2005 to 2010. I know that you guys are all very familiar with it, but I thought a little bit of review would be good. We'll talk about post-arrest care once they get to the emergency department. So cardiac arrest. Out of the hospital, cardiac arrest is the third leading cause of death in the United States. So it's second behind breast cancer, second behind myocardial infarction. It accounts for nearly 400,000, there are nearly 400,000 cardiac arrests annually. And so when you look at that on this bar graph, you can see cancer, number one, heart disease without cardiac arrest is number two, and then out in the field, cardiac arrest. So this is a huge problem and has a fairly high mortality. So 1 out of 4 patients actually get CPR. So 3 out of 4 people, they never even get any sort of attempted resuscitation. And I think that that's a lack of education for the layperson, but then most of the time when this occurs, emergency care isn't able to get there in time. Out of those 100,000 people that do receive CPR resuscitation, only 40,000 survive to hospitalization, or at least to the emergency department. So 1 out of 10 people who arrest actually make it to the hospital. So that's fairly impressive. Right there, our mortality is already down to 10% of making it to the hospital. And if you talk about survival to discharge, only 1 out of 20 people who do have an arrest actually make it out of the hospital with any sort of neurologic recovery that leads to any sort of good quality of life. So clearly, a fairly high mortality, fairly important for us to do a good job and for you guys to keep doing the work that you're doing. So survival is dependent on a few different factors. One is location of your arrest. Is it in the hospital or is it outside of the hospital? And there are differences, obviously, in those numbers. When is going to be the initial rhythm? Is it VT? Is it VFib? Is it PEA? Which rhythm you present with actually does have an important role as to what your survival rate is going to be. Patient factors, obviously medical problems, previous cardiac issues, other chronic medical problems do play an important role into how people will do. And then you guys, rescue factors. We'll talk about some of the things that you do well, some of the things that we do well, and how we can all get better. My remote control is, all right. So if you talk about location of arrest, if you talk about people who have arrested outside, out in the field, like we talked about before, 5 to 10% of people survive to discharge. And you would like to think that if you're in the hospital and you fibrillate in the hospital, your mortality is going to be much higher. But really, it's not tremendously better. It's only about 20%. So if you are an inpatient and you suffer a cardiac arrest, only 19% of you will survive to discharge with any sort of good neurologic recovery. So still, even in a controlled setting, the survival is not tremendous. Children do better. 25% of kids will survive their arrest. And I tend to be a little interactive. So anyone wonder why kids do better than adults? Absolutely right. Kids tend to have more respiratory issues. They don't have that underlying cardiac substrate. So that's absolutely correct. It's more about pulmonary and respiratory. So that's why children tend to do better. They just don't have that bad LV or severe coronary disease or whatever it might be. So we're going to do a little raise your hand, what everyone thinks. We have 3 rhythms. So we have sustained monomorphic VT, we have bradycardia or asystole, and we have ventricular fibrillation. So which one of these rhythms is going to be the most common out in the field? Who says sustained VT is the most common? No one. You guys just raise your hand. It's like doing a poll, a survey. You guys are shy now. So sustained VT versus bradycardia or asystole versus VFib. Which one do you think is most common? VT, VFib, bradycardia? I can't hear y'all, but, and then who's going to survive the best? Who's going to have the best survival? Make a guess in your mind, and when you see the numbers, I'll be honest, I was surprised. So when you look at all these different rhythms, 7 to 10% of out in the field arrests are monomorphic VT, and actually they have the best chances of making it to the hospital. 88% of people who have VT out in the field make it to the hospital. If you look at bradycardia or bradyarrhythmia, complete heart block, asystole, they're 1 out of 5, but only 9% made it to the hospital. And then if you talk about ventricular fibrillation, it is 3/4 of all cardiac arrests, and 40% of them made it to the hospital. So VFib is most common because most of the other things degenerate to VFib. VT will degenerate to VFib, PEA will degenerate to VFib, or excuse me, asystole. So that's kind of the default rhythm of choice. But in terms of survival, VT is actually a good thing to have. So patient factors, we have these discussions all the time whenever people show up to the hospital having had an arrest, how we're going to manage them. Their history is very important. Things that have a negative prognostic indicator are on the left. Things that are actually give them a better prognosis is on the right. So hypotension, pneumonia, renal failure, cancer, if they have a sedentary lifestyle, if they have a history of congestive heart failure, if they're over 70, these are all things that lead to poorer survival. Actually having had prior angina or coronary disease or having monomorphic VT actually have been shown to be a better prognostic indicator, because usually those things have an acutely abnormal problem, and once we fix them with a stent or an angioplasty, they tend to have better survival because we've rectified the underlying problem. So rescue factors, I think that this is a case for you as well as for us as physicians. Important things are experience. The more you do, the higher frequency you have, the better you're going to be at doing what you do. Knowledge base, keeping up to date, doing things. We go to CME conferences all the time. I just went to an ECHO conference. And then the ability to deal with stress. There are some people, when you're in the middle of the cath lab, there are 6 of us that do angioplasty at Grant. Some people break down, some people scream and yell, some people keep their cool. So I think the ability to deal with a stressful situation, direct traffic, and help to delegate responsibility is very important when you are out in the field dealing with this. So this is just an interesting slide, and the reason I bring this up, because we are going to go over some basic things, is that the more you educate, the more you simulate, the better your ability to give good resuscitation. So that's why we're going to go through some basics today, but I think that all of you on your own, obviously you care about education, otherwise you wouldn't be here, but I think to be diligent, go to conferences, practice with simulators. How many people do practice with simulators that give some sort of biofeedback, that compressions are shallow or they're good? Does everyone, I assume, do that relatively frequently? So I think that those are good things to do on a regular basis, because if you look at the bottom curve, those are people who never go for education, or they don't do enough, something like that, where obviously over time, without being brushed up, your quality does degenerate. So because of that, I'm just going to go over some brief changes to ACLS protocol from 2005 to 2010, because there are some differences. You guys already have this memorized. But the important thing on the left, right, ABC changed to CAB, right? It used to be airway, breathing, circulation, so now most paramount is circulation. Circulation takes precedence over airway and breathing all the time, and we'll kind of break that down a little bit more. So circulation was placed first to emphasize the importance of chest compressions, cardioversion, cooling, and the cath lab. So we're going to talk about all 4 of these things today. So why did we bump airway and breathing down? Well, there have been a lot of studies, animal models, that have shown that the metabolic demand when someone is in cardiac arrest and there's CPR going on, they do not require as much oxygen. When you actually look at the numbers, specifically cardiac and pulmonary blood flow is about 25 to 50% of normal rates of metabolism. So because of that, a lower level of oxygen is needed to be maintained whenever you're going through cardiac arrest. So then passive ventilation or even just a non-rebreather is going to provide enough oxygen to the patient while you're performing CPR and doing your compressions. And if you are doing your compressions right, the actual chest retraction creates enough suction to bring some of that oxygen in. So necessarily stopping compressions for an airway is not necessarily the appropriate thing to do unless there is a respiratory issue underlying. There is such a thing as overventilation. This is something where, when I was an intern, we're at codes and some people would bag over vigorously. The faster you bag, it's actually been detrimental to survival. You can do such things as increase the intrathoracic pressure, and if you overbag, you kind of cause this phenomenon called auto-PEEP. It happens in the ventilator in their intensive care unit. You actually increase intrathoracic pressure, which decreases venous return to the heart, and when you decrease venous return to the heart, you actually decrease cardiac output and actually raise the stress level in the heart, where they have higher metabolic demands and people actually have poorer outcomes. And then if you think about it, I just mentioned it, if you stop CPR to intubate someone, you are actually then providing less blood flow to the heart at that time, and that actually also is quite detrimental. So obviously when there's a respiratory cause, you want to obtain a good airway. So let's talk about the 4 C's. So compression, cardioversion, cooling, and cath lab. So they've done observational studies of cardiac arrest out in the field, and it shows that 1 out of 3 compressions delivered is too shallow, so not adequate to really improve cardiac perfusion. Half the time, they say that compressions aren't being done when they should be done. So we're stopping to do things that are not necessarily mandatory or needed. We're checking pulse for too long. We're managing an airway for too long. We're trying to get a defibrillator ready for too long. So I think that, as a group, we don't do, I was on call this weekend at Grant, and I watched some patient code. He actually did well. He survived, but then you watch the way things go on, and they were taking way too long to get the patient intubated, where that probably wasn't necessarily the most important thing at that time. But only half the time are we doing compressions when we should be. And this is not really much better in the hospital. Just like I said, 1 out of 3 compressions are too shallow. We do better in terms of the protocol. Only 23% of the time is being missed when they should be getting compressions. So 3 out of 4 times they're getting their compressions that they need. So compression, it's all about technique. It's all about rate. It's all about fatigue. Recognizing that you can't do compressions, even though a lot of you guys are big and strong. You can't do compressions for 5 minutes, 10 minutes, 15 minutes. They say fatigue sets in about 1 minute. And if you're doing compressions for longer than that, you're actually doing a disservice to the patient. And then we want to minimize interruptions. So obviously you guys know all this stuff, the proper technique, perpendicular, depth about 2 inches. You want to allow enough time for the chest to recoil as it did for you to push in. It should be equal to the compression and the recoil time. And once again, we talked about inadequate recoil results in higher intrathoracic pressure. That does cause cardiac output to be reduced because of reduced venous return. So anyone know what the recommended rate is in a minute? Wow, good job, yes. And so this was cool. They actually said total number of, and so how do we, what guys do you use to help you stay at 100? Nice, very good. I didn't bring this up because one of the Gibbs brothers just died, but yeah, it's staying alive. If you sing that, hum that along, that's the proper rate that you want to deliver chest compressions to. There's actually a nice little study when you talk about important predictors of the return of spontaneous circulation. If you are averaging about 68 to 89 compressions per minute, that's when the most ideal outcomes have occurred. So too few, too little. Obviously, you're not going to maintain perfusion, but if you sing Staying Alive and think of John Travolta, you should do well. So good compressions, why is that important? It allows for you to wash out blood. Whenever you have cardiac arrest, there's hypoxemia. You get the buildup of metabolites that are not good. Inflammatory mediators are built up. And when you allow for good compressions, you get good coronary perfusion, and you do have renewal of these energy substrates. And of course, you want to minimize interruptions. So interruptions, we talked about this before. Airway management, it accounts for 25% of all interruptions. Pulse checks, you should limit them to about 10 seconds. Once again, on Saturday, I was watching this code. People were taking 15, 20 seconds waiting for a Doppler, find a Doppler. People should continue to do compressions even when they're getting those things. And then continue through defibrillation. I don't know how many of you have hands-off defibrillation, but it's okay to keep doing chest compressions when you deliver a shock. Do you guys routinely do that? Keep your hands on the patient when you're shocking? You actually can do that. I do TE cardioversions, and it sounds scary, and one of my EP partners, every time if you're 400 pounds and we're worried about getting enough energy to the heart, he actually will put his hands on the pads while we deliver the shock, and I actually just did it last week. You don't get shocked, you don't feel anything, and you can actually decrease the distance between the pad and the heart muscle, so you're going to deliver a better shock. So one of the recommendations is while you're doing CPR, you continue doing CPR, you have your hands off defib, you charge it while you're still doing CPR, and you can actually shock while doing compressions. It's actually safe. There have been plenty of studies that it's never caused a problem. And I personally have done it 15 to 20 times in the last year. Whenever we do atrial fibrillation, I lean on the patient, I get they jump, I don't feel anything. Traditionally, if you stop compressions and you have your paddles, the average is about 15 seconds of lost time of compressions. While you're analyzing your rhythm, while you're charging your defib, and then you shock them, people lose about 15 seconds. So the key to survival is what you guys do, early defibrillation. The rate of survival for unwitnessed cardiac arrest is greatest when you defibrillate them within 1.5 to 3 minutes of CPR. Once again, good CPR replenishes nutrients and increases the likelihood of success. Every minute a patient remains in VFib or pulses VT, survival decreases by 10%. So the quicker you guys do your thing, the better they're going to do. Hands-off defibrillator pads allow for uninterrupted CPR with the delivery of a shock. Even if you shock them and you shock them into sinus rhythm, their heart and their rhythm are not doing the same thing. There is such a thing as electromechanical delay. So even though the EKG says sinus, that heart is still kind of quivering. It's not beating at sinus. So to do compressions is still going to be beneficial because that myocardium is too stunned to really develop any sort of good cardiac output. Okay? So even after you shock them, still keep doing compressions for 2 minutes before you even check a rhythm. That way you're helping to perfuse blood. So some other changes to the ACLS protocol. Basically, we have fewer pulse checks. For the untrained rescue, we're doing hands-only CPR just because it's been shown to be as good as two-man breathing CPR. The survival is just as good. They took atropine out of the PEA asystole protocol, and then the use of end-tidal CO2 monitoring. So there's been a lot of good data that if you monitor end-tidal CO2, that can give you a lot of good information about the return of spontaneous circulation. It can tell you that if you are giving good CPR, if you have a low CO2, you're not doing good CPR. The higher it is, the better oxygenation and carbon dioxide exchange there is, so then you're providing good perfusion to the organs. Cricoid pressure is no longer routine. They do say the routine use of dopamine, epinephrine whenever you have any issues with bradycardia, and then hypothermia in the cath lab. So here is hypothermia. This is actually my patient who we cooled off last weekend. He was a guy who had open heart surgery, went home on Coumadin, and his INR became super therapeutic. So he came back down from Ashland after he had arrested at Samaritan. So we brought him down and we cooled him off, and we found out why he fibrillated. So he actually had pericardial tamponade from a big pericardial effusion that he ended up going back to the OR and had drained. But we cooled him off for right afterwards in efforts to help maintain his neurologic status. So what's the theory? So basically, whenever you have cardiac arrest, obviously you're hypoxic, you're not maintaining blood flow, and oxygen stores deplete in the brain within seconds. Energy stores, ATP and glucose deplete within 4 to 5 minutes. And so when you lose those energy substrates, you start having issues with neuronal firing. There's a particular thing called gluconate. When your neurotransmitter gluconate is released when you have this hypoxia, almost as a stress release. And it actually increases intracellular calcium, causing this excitotoxic cell death. And anything with cell death obviously is not good. So we want to help minimize any of these issues. Actually, once you restore the rhythm and you actually get better blood flow, that initial reperfusion and reoxygenation actually can worsen damage. once you've been without blood flow and then you give a lot more blood flow and you get a lot more oxygen, you actually get the development of these oxygen-free radicals. And we've heard enough about that, that oxygen-free radicals increase pathologic changes in your blood vessels, in your body, to where you do get more oxidative damage. What happens is normally the brain is able to regulate the blood vessels, how they dilate, how they constrict. All that goes out the window when you have these inflammatory mediators, and it actually causes cerebral edema. You can get brain herniation, and then just the regular hypoperfusion is what causes people not to recover neurologically. So when we lower their temperature, our goal, normal body temperature is 37 degrees centigrade. Our goal is to lower their body temperature to 32 to 34 degrees centigrade. And there are different ways to do that. When I was a cardiology fellow, we actually put a catheter in their vena cava and gave it centrally. That was shown not to be necessarily any better than putting ice bags on them. So you guys can put ice bags on them, lower their temperature. I'll show you that picture again. There are pads you can put on the patient to help cool them down. You can use cold saline to help cool them down. Ultimately, you want to get them down to 32 to 34 degrees. This hypothermia causes a decrease in the brain metabolism, essentially putting them in hibernation. And when you do have that hypothermia, you're going to get less of that gluconate secretion, which causes that cytotoxic cell death. So basically, we put them into hibernation. And all of this also suppresses inflammation so that hopefully with time, there's not going to be as much neurologic damage. Our goal is to prevent worsening damage, not necessarily fix what's already happened. Because there are plenty of people who come to us, we cool them down, and it's really done nothing for them. Here is a study from 2002. This was actually done out in Sweden. So this technology has been around for 10 years. When I was in training, we were probably doing this 6 or 7 years ago. We've been doing it at Grant probably about 4 or 5 years now. Basically, people who were not cooled versus who were cooled, the people in the hypothermia protocol had a better survival. It was by 23 to 40% had better outcomes long-term, better neurologic recovery. And this is from 10 years ago. So that's why it essentially is becoming the protocol for all cardiac arrest patients. If it's an infarct, if it's not an infarct, they're all getting cooled down. So these are some of the indications, and I apologize that it's such a small slide, but basically any adult patient who is resuscitated from an out-of-hospital cardiac arrest should be cooled. So they should be taken to a center who has the capability of performing hypothermia. People who are generally not arousable, you don't want to necessarily cool someone down who's awake and alert. Then you want to talk about rhythms like VFib, VT. Those sorts of things are going to be very well treated with hypothermia, not necessarily because it's helping the rhythm, but because you're helping the underlying problem. So recommendations, cardiac arrest, as we talked about on the last slide, temperature of 32 to 34 degrees. They need to be paralyzed. A lot of times they will shiver a lot, and that can actually be detrimental to them. Ideally, we want it to be 2 to 8 hours within arrest for ideal outcomes. And then we cool them for typically 12 to 24 hours. So here's our guy. The big blue gel is just that cooling pad. So we kept him cool for about a day, day and a half. And after he got his pericardial effusion drained, he had about 1 liter of blood in his pericardium. He actually is awake and alert. He's still on the ventilator, but he's appropriate. So that's what we always strive for, is that people are appropriate from a neurologic standpoint. There was another young girl that came in this weekend, 38 years old, cardiac arrest, VFib. She had a potassium of 1.7. Boyfriend did CPR but didn't call EMS, and unfortunately she has not had any neurologic recovery yet. But we cooled her for a day and a half now, and we're still waiting to see if she wakes up or not. So cath lab. This is what we do. Not every cardiac arrest goes to the cath lab. This is a conversation we have with the ER doc as soon as an arrest comes in. We say, what's the EKG look like? How are they doing hemodynamically? Do they have a history of bypass? These sorts of conversations always occur whenever we talk about if they should go to the lab right away or should we cool them down and let them get better. This 38-year-old girl who came in Saturday night, EKG was normal, no cardiac history. She had an explainable reason for VFib arrest. Her potassium was 1.7. Normal is 3.5 to 5. So there wasn't a big indication for me to rush her to the lab Saturday night. That decision to go for emergency cath, once again, is based on the clinical scenario. And typically, if there aren't a lot of risks, we'll let them cool down. And if they wake up and they are appropriate, then we'll talk about stress test, cath, defibrillator, those sorts of things. So our job in the cath lab is to revascularize the patient appropriately. If they need a stent, we give them a stent. If they need bypass, they get a bypass. We want to stabilize them hemodynamically, and there are times that we can even initiate. In some places, they actually cool them in the cath lab. So this is what we always love to do. These are our heart caths, and here's going to be one guy. I hope you can see it well. This was actually a cardiac arrest from about 2 years ago. We brought him up to the cath lab. We did him emergently. He had anterior ST elevation on his EKG. So typically when somebody comes up to the cath lab, we always shoot the non-culprit vessel first. So this is moving a little fast, but basically this is a catheter in the right coronary artery. Wherever the dye fills nice and smooth, the artery is open. You can see right there in the middle of the vessel, kind of right there, there is some degree of blockage, some degree of stenosis. But that's not his problem today. Here is going to be the left system. The left main is right up here. This is the circumflex. So where the dye fills, he has a lesion right there. This is the diagonal, and the one thing he's missing is his LAD. So now we look in another angle. Here is what we call the spider shot. Here's the left main. Here's his LAD. Here's his ramus, and here's a circumflex. So you guys can see his LAD is stumped off. So he has an acute anterior infarct that led to cardiac arrest. He still had ST elevation, so we took him emergently to the cath lab. So he has triple vessel disease. His circumflex is diseased, his right is diseased, and his LAD is occluded. But we had no idea about neurologic function because he was sedated on the vent. Ideally, if you came into the hospital and we did this heart cath and you were walking, talking, we would send you for bypass. But we didn't know what his neurologic function was. So I actually called a cardiothoracic surgeon to the cath lab, and he says, I'm not going to take him because I don't know that it's going to benefit him because we don't know if he's awake or not. So what we ended up doing is, you can see here's my wire. I have a wire down this LAD, and we've recannulated the LAD. This is just another picture of that same vessel, and you can see where the dye fills nice and dark black, that's open vessel. That LAD is gray, and it's kind of hazy and kind of snotty. That is thrombus and plaque. So a plaque had erupted in his LAD, and we've now recannulated it with this wire. Here's a little, I hope you don't get a seizure. There's a little black dot there where that's a little catheter that we take that in that vessel over the wire to help kind of suck out some of the clot, clean it out. We know that there are good studies that if you do that intervention first and you clean out some of the clot, they do have better outcomes. So this weekend I was on call, we had 3 infarcts, and all 3 we aspirate clot out first because it really debulks the lesion and there's less likely stuff to go downstream and cause more problems. So you can see that his LAD is a little bit better, not as cheesy and slimy. Here's a balloon just to kind of help make some space to deliver a stent. This is after the balloon, so flow's a little better. Here, I put a wire in this side branch just to protect this branch when I put the stent in the LAD. The one thing is, we don't take plaque out, we just push it around. So when I put the stent in, we want to make sure we don't send plaque down that other artery. So empirically, it takes 2 seconds to just put a wire in that other vessel, and if I shift any plaque down there, we can always go and clean it out with the wire still there. So here's a stent. I'm just positioning it. This is us inflating the stent. Oh, these just still positioning it. Hold on. I didn't take a picture of the stent going up, but this is basically after the stent in place. We've preserved that side branch, and we have good flow in the main artery. So you can see how the flow up top is much darker. It's much straighter. There isn't as much thrombus in there. But then now that we have better flow downstream, we see there's a little mid-LAD lesion. So we go ahead and take care of that while we're there. That's another little stent. It was a stent. So that's after the stent here. And we pinch that side branch. It's a small branch. We're not going to worry about it. That's what medicines are for. And then afterwards, because he was still hemodynamically, oh, here's just a picture of that spider shot again after we've stented the LAD, showing that we now have a nice vessel and that we've maintained all of our branches. So he wasn't doing very well hemodynamically, so afterwards I did put what we call an intra-aortic balloon pump. So these are pretty common. This isn't too fancy, too exciting. When people have cardiogenic shock after an arrest or even without an arrest, we typically can put in one of these devices. We put it in through the groin, and you can see it's just a big fancy balloon, and it's timed to their heart rhythm. During diastole, when the heart is relaxed, that's when you get most coronary perfusion. So then the balloon will inflate during diastole so that it pushes blood back to the heart to better fill the coronary arteries. Normal cardiac output is about 4 liters. This will give you a half a liter. So it gives you some support, not tremendous, but it can, and this was all we really had till a couple years ago. Now we have this other new toy. This is a little catheter. It's called an Impella. It is a percutaneous left ventricular assist device. It basically, you can actually have someone in VFib and they can look at you and talk to you as if they don't know what's going on because it provides 2.5 to 3 liters. There's a bigger device that provides 5 liters of cardiac output. We put this in the cath lab. There have been people who've been having open heart surgery and they can't get off pump. They actually bring them up to the cath lab and we put this in the cath lab. It basically helps to unload the heart. It can basically let the heart rest and provide 100% of the cardiac output that it needs until things recover. This is the size of the catheter. So really small, goes in through the groin and really has really helped us a lot from a cardiogenic shock and arrest standpoint. I forgot to touch upon other things that are new, and I forgot to make a slide, but basically the only other interesting thing is that just in January of this, or February of this year, they published a study out of Japan out in February that they're talking about getting rid of epinephrine may be taken out of the cardiac arrest protocol. There are some studies that show initially patients do well, but if you look at the 3 and 6 month mortality, people who received epinephrine actually had poorer outcomes than patients who did not receive epinephrine if they received vasopressin. And I apologize, I didn't put that slide in the talk. But that is something that may be new or different. Next time they redo ACLS, they may take epi out of that as well. So basically, I'm actually wrapping up here. Cardiac arrest, 3rd leading cause of death in the United States. Only 1 out of 20 out of the hospital arrests survive with a good quality of life. And really, everything is all about timing and initial evaluation. So we want to shock them early, shock them often as needed, and provide good quality CPR. And when it's performed correctly in the field, mortality does improve significantly if we do things right. Obviously, there are a lot of changes to the ACLS protocol that we talked about, and I think from our standpoint and after you guys bring them in, we do the hypothermia quite frequently, and of course, we always take them to the cath lab when they need to. Any questions? And I actually put my email because I think this is the 4th or 5th year I've done this, and I struggle to figure out what you guys want to hear about. So if you guys have any suggestions, if I'm going to be invited back next year, I never give Mark my slides ahead of time. So if you guys have any topics, email it to me. We can try to touch upon things. And then if you guys are ever down at Grant, we have guys and gals up in the cath lab all the time to watch heart caths whenever you want. If you're bringing an infarct, you guys are more than welcome to come up and watch. Any questions? I think it's lunchtime.